Good afternoon. Thank you all for attending this progress report. I'm really excited to take you on a journey through my PhD, which focuses on novel insights into the neurosurgical interventions for patients with drug-resistant epilepsy. My name is Arashk Zabihi, and as a neurosurgery resident, I'm committed to advancing the field of minimally invasive neurosurgical intervention. My vision is to improve the quality of life for patients living with drug-resistant epilepsy, and my mission is to investigate novel interventions in order to provide an increased standard of care for these patients. Currently, we have two ongoing projects. Our first project aims to investigate two interventions in a rare disease called periventricular nodular heterotopia. And the second project is dedicated to evaluating the surgical outcomes in patients with mesial temporal lobe epilepsy. Let's take a closer look at the first project, which focuses on investigating the safety and efficacy of minimally invasive neurosurgical interventions in patients with periventricular nodular heterotopia-related drug-resistant epilepsy. So epilepsy is a global challenge affecting over 50 million people worldwide and around 37,000 in Hungary. It leads to lifelong disability, loss of productive economic years, and a threefold increased risk of premature mortality. Periventricular nodular heterotopia is a congenital brain malformation, which accounts approximately 2 to 3% of all cases. Based on recent data, 60 to 90% could achieve seizure freedom through innovative, less invasive interventions. The traditional open surgeries are rarely performed due to the deep-seated manner of this disease, and this could cause several injuries in the brain. So notably, less invasive, minimally invasive interventions have emerged, such as the Stereo-EEG-guided radiofrequency thermocoagulation and the MRI-guided laser interstitial thermal therapy. The critical gap in the literature is that there is no consensus regarding the optimal approach of the surgery. And we aim to investigate the safety and efficacy of these two interventions. The clinical question seeks to determine whether the MRI-guided intervention provides a better seizure control compared to the stereo-EEG radiofrequency thermocoagulation in patients with drug-resistant periventricular nodular heterotopia. As our PICO framework shows, we are investigating two interventions in order to determine their efficacy in seizure reduction and to assess the functional deficits. Our hypothesis is that the MRI-guided therapy provides a better clinical outcome compared to the stereo-EEG-guided thermocoagulation. The clinical implication is a sustained seizure control while reducing the treatment-related complications, which could lead to a shorter hospitality. We conducted with the finalized surgery, we conducted a search, and we found that no previous meta-analysis have been conducted on this topic, which highlights the novelty and the importance on the research. And initially, we found more than 400 articles. After the duplicate removal and title and abstract selection, we ended up with 16 full-text articles. And through citation chasing, we found one additional article that will be included in the meta-analysis. Regarding the progress of our first project, we have finished the data extraction, and currently we are at the state of statistical analysis and risk of bias assessment. Our second project aims to investigate the minimally invasive surgical outcomes in patients with mesial temporal lobe epilepsy. The mesial temporal lobe epilepsy is the most prevalent form of focal epilepsy, affecting more than 12 million people worldwide. While 65% of patients can achieve seizure freedom through adequate medication, more than 4 million remain drug resistant, which can lead to several consequences. The temporal lobe involves essential brain regions such as the amygdala and the hippocampus, which plays an important role in the memory formation, learning, emotional regulation, spatial navigation, and neuroplasticity. The gold standard therapy has been selective anterior temporal lobectomy and selective amygdalohypocampectomy. However, recently there has been an increased propensity to use novel, less invasive interventions, such as the previously mentioned stereo-EEG radiofrequency thermocoagulation and the MRI-guided laser interstitial therapy. However, even with these new techniques, the literature indicates that there is a varying degree of neurocognitive deterioration. So we aim to compare the outcomes of these interventions to determine the best approach in order to reduce adverse cognitive effects. Our clinical question seeks to determine whether the MRI-guided intervention provides better cognitive outcomes compared to the stereo-EEG-guided thermocoagulation and open surgery in patients with drug-resistant mesial temporal lobe epilepsy. In this study, we are comparing 3 interventions, and the outcome is measured with different neurocognitive tests. We are also interested as secondary outcome in the postoperative rate of seizure reduction. Our hypothesis is that the MRI-guided intervention provides a better outcome comparing to the other interventions. The clinical implication includes reduced treatment-related neurocognitive symptoms, and by revealing these complications, we can also provide adequate postoperative patient rehabilitation. We conducted a preliminary search across 3 major databases. We found no meta-analysis nor Prospero registration, and in the following steps, we will assess the feasibility with the statistician. In conclusion, both of the studies aim to address critical gap in the management of drug-resistant epilepsy. Thank you all for your kind attention, and I would like to conclude the presentation with one of my favorite quotes that says, "You can't ever reach perfection, but you can believe in an asymptote toward which you are ceaselessly striving." Thank you all.
Thank you for these excellent presentations. Are there any questions? Yes, you first.
Hello.
Hello.
Beautiful presentation. So, how do you diagnose the focus of these epilepsies?
Mm-hmm. Thank you for the question. It's really important to diagnose the so-called seizure onset zone. So where the epilepsy starts, you can diagnose it with the EEG. The stereo-EEG means that we are using electrodes, and with different electrodes in the brain, we can measure and especially locate the focus of the epilepsy onset zone. With the MRI, we can see only the lesion in the brain, but if there are many lesions, we cannot tell which one is the seizure onset zone.
Yes?
Thank you for your beautiful presentation. When do you go for operation? So when do you consider a patient or a disease, an epileptic disease, drug resistant?
Mm-hmm. Based on the International League Against Epilepsy, a combined therapy of 2 anti-epileptic drugs used for at least 6 months, if the seizure is not reducing, so it has no effect, then the patient can go to the surgeon and to evaluate if the surgery is an opportunity or not.
Thanks.
Thank you. Next question? Yes.
Yeah, I would like to have a question related the first topic, that why do you think that those patients who were treated with the MRI-based intervention will have a better outcome?
Thank you. With the MRI intervention, in case of the periventricular nodular heterotopia, the disease is always MRI positive, which means that we can always diagnose it by MRI. There are some epilepsies that shows shows nothing on MRI picture. And also it's less invasive, as there is just one cut. We use just a single thermal coagulator, while in the stereo-EEG we use more electrodes, which has more entry point, which has more an increased risk of wound infection, or basically this is my opinion, so it's just a hypothesis, but it really depends if it's on the left or right side. For example, if there are more nodules, more than 2 or 3, maybe it's better to use the stereo-EEG, or it has no difference between the two techniques.
Okay, thank you.
Thank you.
Welcome.
Further questions? Yes?
And what is your current practice in your hospital? Do you use these minimal invasive techniques, and when?
Thank you for your question. The stereo-EEG technique is used in Hungary. The MRI one is really expensive, so it has been accepted by the FDA in 2007, and there are just a couple of centers using this technique. We don't have MRI-compatible operation room in Hungary.
Any other questions? Okay. If not, I will have the last one. My question is based on your impression from the second project.
Yes?
Do you think that this MR-guided procedure will be better than the other one? So only the impression, because I know that you didn't do the data analysis.
Yeah, first, my impression was that it might be better. Then, as I deep diver in the articles, I saw that it uses laser energy which dissipates in the surrounding zone, so actually might cause even more damage than the stereo-EEG, which is much focused, so much targeted. So we will see the outcome. I'm not sure if the MRI is really the best option in this case, just a hypothesis.
Okay.